And in terms of if you were describing it to a dermatologist who wanted to use it in their practice, what would you say that you'd actually use this for, kind of thing?
So clearly I tell them that it's great because we can go deeper, it's very quick to do a scan, but we don't have the cellular resolution. So we're really looking at mostly BCC, where the shape of the tumor is easier to diagnose, and it's better to follow up treatment when you know the diagnosis already, so you don't have a problem, or tumor where you have already a little biopsy, and so you're trying to do a mapping of the tumor. For example, I receive a lot of cases from radiotherapists who need to do some radiotherapy for a BCC on the nose, and they don't know where to put their field, so I'm trying to help them with that. And I found OCT better than confocal because we can go into depth, so we can really see the first millimeter there. So BCC is the main indication for me. The melanocytic lesions are too complex, even with cellular resolution, to do much about the machine. I guess what is great also about the machine is all the measurements, the possibility to see the blood flow, to measure the depth of the lesion. So in terms of cosmetic, or when you want to do some laser treatment, and it seems to be a very good machine also, but because I'm a skin cancer person, I'm using it mostly for BCC.
Okay, so if someone came in with like a field of lesions, like several lesions that are all, some of them are very kind of suspicious or potentially suspicious, what would you use it on every lesion, just quickly scanning, or how does that work?
So normally it's one lesion that we have a look at, and most of the time our question is it superficial or is it not? If it's superficial, we can do Aldara, we can do cryo. If it's not superficial, we should do a biopsy or just remove it. And so it's really a management things. And you know, our patients in Australia often have 10 of these little pinkish impossible thing, and so we scan quickly and we triage what is superficial, what is not, and so we go a lot faster than having to do 10 biopsy and then waiting for 2 weeks to gather all the results, organize everything. So the patients are very happy, and we're happy because we go faster.
Okay. How does it normally work? I mean, do you say that you get like a certain number of more patients kind of through the door? That you see more patients generally?
No, I can't see more patients. Yes, I guess, yeah. It's a question of time, go faster, a question of confidence also. So you can do diagnosis with dermoscopy, we're not bad at that, but we're a lot more confident when we have a scan of OCT. And yes, it avoids for all the very superficial things, it just triage a little bit better. We still do biopsy and we still remove the BCC that are not superficial.
Okay.
So it's not like we're not doing any surgery anymore, but yeah.
Okay, and so if so dermatologists who say, you know, that if someone presents with various different lesions, some dermatologists in Australia will just say, you know, I can tell by eye, I've been doing this 30 years, I don't really need that. Why would you need that, if you like?
Well, you know, I'm a very humble person. I think we still need to learn things, and I will never say I know. So I found any help is useful. I've done the first study with OCT where we biopsy all of these little pinkish things because we wanted first to learn, and also it was a study, so we had to have a gold standard. And I've been very surprised that a lot of things that we were thinking were superficial BCC were not. We found one melanotic melanoma that was absolutely impossible to diagnose. It was not looking melanoma in any way. And a lot of things that were other things, so granuloma, actinic keratosis in particular, a lot of things can mimic things. Most of the time it's okay, you know, you do a mistake and you see the patient 6 months after and you can correct your mistake. But yeah, for example, this melanoma was already open 8 millimeters, so if we haven't biopsy or just cryo quickly, I don't know what would have happened.
Okay. And so the machine kind of helped you. It didn't obviously diagnose melanoma because you can't kind of ask it to do that, but it kind of helped you realise that it was melanoma when previously
there was something wrong there. Yes, but again, it's not a good machine for that, and I would not advise to use that for that. It's really on the triage of the BCC that I found it amazing, and then follow-up of treatment and mapping to know where the margin are and recurrence when it's coming back and that sort of things.
And how does it work in? Because I'm just thinking in Australia it's quite different how the dermatologists and the plastic surgeons and everyone is set up. So I'm kind of wondering who is the OCT machine kind of right for, because previously in Europe, for example, with like Dr Welzel, they're quite big on Mohs surgery, but here a lot of dermatologists tell me that Mohs surgery is not so big.
It's a little niche, but dermatology is a little niche in Australia. So yes, Mohs surgery is not for everybody. And clearly the machine can help to pre-Mohs. I don't think the machine needs to be with Mohs surgeon only at all. I think it's really good to have it in center where you see a lot of BCC, but that will be a lot of center in Australia. It's #1 disease in Australia. So.
Okay, so for plastic surgeons, could it be useful for?
I think so too, to have a look at what they're doing. I think, in terms of plastic surgeon, they can also send to referral center. So what we're doing at MIA is we have a lot of specialists sending here to have the scan, and then we draw on the skin and send them a photo of where to cut or where to put their radiotherapy field or that sort of things. So it depends of their practice basically if they see a lot of BCC or not.